All right. Good afternoon, everyone. Great to see everyone. Happy Thursday. I am Linda Montgomery. I'm with Family Medicine. I'm Vice Chair of Education, and I'm standing in sort of not the best stand-in for Amy Gardner, but I will do my best. As you know, she is in Scotland on her Fulbright, which is incredible. But she asked me to start out and introduce Dr. Vipler, who I think many of you know. So for those who don't know Ben, Dr. Vipler is an associate professor within the Division of Hospital Medicine. He completed his undergraduate and medical school training at the University of Miami, after which he commissioned as an officer in the U.S. Navy and completed his residency and chief residency in internal medicine at Walter Reed. He then served his military commitment in Virginia Beach, where he was an associate program director for one of the Navy's internal medicine residency programs. After his honorable discharge, he completed a general internal medicine fellowship at Penn State, where he received a master's degree in education. Ben currently serves as a director for one of the university hospital's longitudinal integrated clerkships. He has a diverse scholarship interests, and as you will see, they mainly focus on transformative learning theory. He's presented at national and international education conferences, has published work in many different venues, including the New England Journal of Medicine, Academic Medicine, and the Journal of Graduate Medical Education. On a personal note, Ben has a supportive physician spouse, who many of you know, two rambunctious daughters, and given the time of year, will point out that he is a huge college football fan. Go Canes. I had to look up the Canes, but I think you probably know they're from his alma mater in Miami. So great to have you with us, Dr. Vipler. Take it away. We will have,
Thanks,
by the
Linda.
way, we'll have some questions at the end. We'll also have a QR code. Please do fill out the survey at the end. Thank you very much.
Sure. Thanks, Linda, for that introduction. And as I mentioned in the chat, thank you for joining me on this lunch hour on this fine Thursday, learning a little bit more about transformative learning in the health professions. I don't have any conflicts of interest, but I will highlight that some of the scholarship that will be presented today was funded through a prior institution of mine. Let's start out with a screenshot from our University of Colorado School of Medicine website. And like many websites from AAMC accredited universities around the country, we have a lot of lofty aims, rightfully so. We have a commitment to decreasing health disparities. We want to increase health equity. And we want to ultimately transform the healthcare landscape. But how do we do that? How do you teach that? Looking through the participants, I don't know if I see the Dean of Admissions here. We could say we could recruit for these characteristics, passions for these things. But do any of these require some sort of transformative educational experience or even life-changing experience during the 4 years of our undergraduate medical students at the University of Colorado? So taking that one step further, I want you to think back to your life-changing experiences that you've had. And this could be in or outside of healthcare. What made them life-changing? Was there anything in particular that sparked this transformation? Was anyone else involved, or was this more of an internal process for you? And what actually changed? Did you have a different perception, a different worldview? Were you doing things different afterwards? So hopefully by the end of our time together, you'll understand a little bit more about what I mean when I say transformative learning theory. The term transformative in health professions education often gets thrown around a lot, even in that statement that I showed from the university website. But what do I actually mean by transformative learning theory, and how does that look within the health professions education? Now, I'll say that I will use some examples from the pandemic, but I use that as sort of a laboratory or a vessel to explore this educational theory, and not necessarily that's not necessarily the focus of the content of this talk is to learn about COVID. It's more about to learn about the process. And ultimately, it's my goal that you'll be able to apply some of the things that we discussed today to your own educational domains so you can achieve the outcomes that you wish in your educational journey. I do have the chat open, so feel free to throw questions in there. I'll be monitoring that as I go. I'll start out with another story. So as mentioned in my intro, one of my roles as an associate program director in the Navy was chairing the clinical competency or promotions committee for a residency. And often there would be two different types of, call them phenotypes of residents that we would run into when residents struggled. Often it would be like resident A, where they were identified by the clinical competency committee as struggling, and we would put them on a remediation plan or a performance improvement plan. The resident would check all the boxes that we had, we'd take them off the plan, and then 3 to 6 months later, they'd be identified again by the clinical competency committee, and we put them on a remediation plan, check all the boxes, take them off the plan. And this would happen over and over again. And sometimes those students didn't graduate, and sometimes they did, even when they may not, should not have. And then there was a different type of resident, resident B, where they would similarly be identified by the clinical competency committee as struggling. They would be put on a remediation plan. And then the next thing that we would hear from faculty all around the institution was, they're like a new doctor. What happened? And that was what really inspired me to make the connection to transformative learning theory. I read this quote in an adult education book that transformative learning is learning that shapes people. They're different afterwards in ways both they and others can recognize. And this is what I saw in resident B that I didn't see in resident A. And I wanted to know why, because obviously if we could capitalize on this and apply it to resident A, maybe we'd have a lot more resident Bs and a lot more successful learners. And again, this spans the undergraduate and graduate medical education and other health professions education realms. Now, this theory dates back to the 70s when an educational theorist named Jack Mezirow outlined this 10-step, I don't want to call it a process, but 10 assumptions that underlie this theory that are often in place, but not always, that leads someone to adapting a different, open, more inclusive worldview in this transformative learning experience. This is too complex for me. I'm a simple guy. So theorists since then have really distilled it down to 4 components. So the first is this disorienting dilemma. Something in life, usually an emotionally charged life event, will sort of shock the learner and lead them down this cascade. I'll give some examples in future slides what that looks like. And then the student or learner looks at them, it looks internally and says, you know, what, something bad happened or something challenging happened that questions the underlying assumptions that I had about the world, about life. Why is that? And there's a lot of reflection that goes on there. The third step, what's called discourse or rational discourse, goes beyond that individual and takes into account mentorship or coaching from a superior or an educator or figure to help them provide alternative worldviews that they could adopt. And then the last is action. So that action could be a change in self-perception, a change in worldview. It could be solidifying or reconfirming worldviews that were expressed before. So it doesn't necessarily need to mean change, but can sort of solidify that. And I'll point out that by definition, transformative learning should be positive action at the end. So something beneficial, a more open or inclusive worldview. I'll give an analogy to maybe the contrary. So for the Stranger Things fans in the audience, let's say there's a disorienting dilemma, like a student witnesses unprofessional behavior. And if the student adopts that unprofessional behavior as their own, maybe promotes cynicism within the healthcare space, I would often call that the hidden curriculum, living in the upside down. But if they see this same professionalism lapse and they say, you know, I'm not going to do that. Not only am I not going to do that, but I'm going to foster better professionalism in my colleagues, maybe lead up and sort of teach my resident fellow attending, whoever had that professionalism lapse, that this is not the right way to do things. I would call that the transformative learning experience that the learner had. So two different outcomes from a very similar event at the beginning. And this is happening all over in the healthcare space, as you can imagine. We have a rich environment that is rife with opportunities to have transformation. So much so that when Julio Frank in 2010 authored this Lancet Commission on a new era of health professions education, he identified two components, interdependence in education and transformative learning, that are ultimately required to lead to equity in health. Quick plug, he is giving a joint Zoom lecture through our own Office of Bioethics, if anyone is interested. But I'll point out that there may be some balancing measures, right? Some of these emotionally charged life events can have unintended consequences. So I like this quote. What right, this is as educators, what right do I have to encourage you to question what you believe? When is it a responsibility and when is it an imposition? When is it empowering and when is it destructive? And I'll highlight this article, which was, I think many of you have read. If you haven't, I'd recommend it. And it was somewhat controversial when it came out, but distinguishing the difference between necessary from unnecessary discomfort, I think is critical in this cascade of transformative learning. And also having the opportunities for reflection, the educators and guides to move that transformation forward. And this is in the literature. So Susan Van Schalkwyk's group, she's out of South Africa, published the first literature review on transformative learning theory in health professions education back in 2019, and had similar conclusions that I brought up already, that healthcare has a lot of unfamiliar settings, uncertainty, complexity, and all of these are potentially transformative. As mentioned, this was the first literature review of its kind, but as noted here, they did exclude non-undergraduate literature, so excluded graduate medical education literature. And I'd point out that most of the literature reviewed in this and most of the writing around transformative learning theory and health professions education at the time was focused in the nursing literature. So we sought out to evaluate what this looked like in graduate medical education. We had a idea that people are probably writing about this stuff in the GME space. They're probably, these events are probably occurring, people are transforming, but it's probably using different vernacular. As mentioned, the theory was coined in the adult education realm, so sometimes medical education or health professions education is a little bit slow to adopt some adult education theories. So I'll point you to the right side of the eligibility column in our literature review on TL and GME. One thing that we did, in addition to including articles that specifically address transformative learning, we looked to see if articles contained those four components that I mentioned of the theory: disorienting dilemma, critical reflection, discourse, and action. And even if they didn't explicitly mention transformative learning, we included those articles in our review. So I'll jump to a couple of themes that we noted in our review. Now, I'll use a pretty broad definition of professionalism here, but most of, and we map this to a lot of the ACGME core competencies, and the competency that kept coming up over and over again, while all competencies were covered, even medical knowledge, which was kind of interesting, professionalism kept coming up over and over again. So if a learner, I guess a resident or fellow, was struggling with professionalism, often it took a transformative experience to overcome that. Similarly, a lot of the literature on professional identity formation did overlap with transformative learning. But I'll say that not all professional identity formation did start off with a powerful disorienting dilemma. There are other ways to develop your identity as a physician. In particular, from the empirical literature that we evaluated, there was an emphasis on primary care. So we did an international search, so some GP residencies, general practice residencies, family medicine residencies, internal medicine residencies, and primary care tracks were overrepresented in the studies on transformative learning. Interested in the chat if anyone in those fields want to throw in some hypotheses as to why that may be. As mentioned with professional identity formation, transformative learning was happening in graduate medical education, as you can imagine, but it was often going by other names. And finally, there were notable gaps within the GME literature on transformative learning. In particular, we noted there was very, very little written about diversity, equity, and inclusion, and how these experiences, there was writing about disorienting dilemmas, but not necessarily steps 2 through 4 that could be accounted for in a transformative experience. So that was my first foray into the theory, but I was very curious. Up until this point, I was more of a quantitative researcher than a qual researcher. And the first thing I think of is, how do we measure transformation, right? Kind of an esoteric concept, but there must be a way. And interestingly, the first author there, Dr. Heather Stuckey, was at my institution where I was training, and I had developed a data collection tool to evaluate both the processes and the outcomes of transformative learning theory. So I had met with her, and we were looking at, what should we evaluate? What's the best laboratory to evaluate how and if and how transformation is happening in medical students or residents? And we were looking at struggling learners, obviously, given my experience with that, resident A, resident B, and then COVID hit. So as like many in the audience today, that probably derailed my research plans a little bit, and like many of you, it did as well. But then I thought to myself, is COVID just a big disorienting dilemma? Now, traditionally, what are disorienting dilemmas? Death of a loved one, being a victim of a crime, losing your job. Those are all very individual experiences. And what I went looking for was, have there been large scale group events that have been described in the literature as leading to sort of a group transformation process. And I did find some literature around this after September 11th. So felt worthwhile to study. So we embarked on a pilot study looking at the transformative learning of medical trainees during the COVID-19 pandemic. We included physician assistant students, medical students, residents, fellows, and we looked at, as mentioned earlier, the processes and the outcomes of transformative learning. And while a little bit outside the scope of the talk today, I do want to highlight this cognitive rational process of transformative learning is what I discussed before, that 4 steps: disorienting dilemma, reflection, discourse, action. Extra rational, I won't get into too much here, but it has to do a lot with having epiphanies, or often religious transformation, or art-based transformative experiences, which we'll come back to. But the social critique perspective is interesting, where it's often the same early steps of the cascade, but ultimately the learner doesn't necessarily transform themselves, but has desire and ultimately outcomes of transforming society. And then again, different outcomes we looked at were an increase in self-awareness, where the learner may be acting differently, having an increase in openness or a shift in their worldview. So of the outcomes, our single center study found that COVID, what did it do for learners? If it did lead to transformation, it increased self-awareness. Some of the hypotheses around this were a lot of time for self-reflection and time alone at home, binging Netflix shows. And then the processes that were highlighted most were, again, the cognitive rational process and the social critique process. For those who are in the undergraduate medical education realm in the audience today, I wanted to highlight that something that we found interesting is that students, more likely than house staff, were to have transformation as a result of going through the COVID-19 pandemic through the social critique process. And we elucidated some of the reasons why in some of our qualitative analyses of our open-ended questions in this study. The data collection tool has 2 open-ended questions about, or really about describing if and how the pandemic impacted your life and ultimately changed your life. So we did a content analysis on those questions. We noted that some people actually noted positive change from the pandemic, which was interesting. Less traffic, things like that. Kind of very superficial comments. Negative change, as you can imagine. I'll jump to no change. This was a little bit surprising to us that some medical students, other than saying, well, things switched to Zoom, didn't really note a major change in their life. But the one that we coded as existential change most mirrored what we would call transformative learning theory. And I'll give you two exemplar quotes, the top from a member of our house staff and my former institution's house staff, and the bottom from a medical student. So COVID showed me how leading medical experts and institutions have little to no interest in operating on an evidence basis and adapting as more information is acquired, and instead are more in favor to conforming to an underlying social moral. In the bottom, going back to the social change perspective, COVID-19 opened the discussion for structural racism in the healthcare setting, as well as in other settings. I became more aware of what is going on and more vocal about what we can do to change it. So same disorienting dilemma, focus on social change. Again, a couple of take-home points from this pilot study that I wanted to use moving forward is these large-scale life events often increase self-awareness in our population, again, focused on the cognitive, rational, and social critiques perspective of this change. There was some link between the undergraduate students having more of a focus on social critique and social change at the end of it. And again, interestingly, something that we found not going into the study that we didn't think we would was individuals from COVID having either no change, or there was a disproportionately high number of negative change, which didn't lead to transformation. So what were the steps that were missing there? But we wanted to dig a little bit further and hear more individual stories. And this was sort of a transformative experience of my own, getting kind of meta here. And this is where I shifted my focus of my own personal scholarship a little bit more into the qualitative realm. So we sat down with a number of house staff who were responsible for taking care of COVID patients during the early phase of the pandemic, the first peak at our institution. And this was our aim. How do residents and fellows engage in transformative learning through their experiences with COVID positive patients admitted during the initial peak of the pandemic? So we did a semi-structured interview, qualitative interpretive study, again, single center during the time frame that you see there. Ultimately had a broad mix of medical and surgical specialties, as well as undergraduate and graduate medical, as well as residents and fellows. And the three themes that we found in our study were, even though residents and fellows were taking care of frontline patients during the first peak, they often had a sense of guilt that they could be doing more. There were things that they learned from going through these experiences, and this is getting back to, can medical knowledge be gained through transformative experiences? I think it can. There were things that they learned that they had seen through the literature and had lectures on, but learned only after experiencing it themselves firsthand. And then there were very unique venues and processes for reflection that we didn't anticipate. This was about when I started collaborating with an organization that I didn't even know existed, I'll admit, before embarking on this study. But for those unfamiliar with the Graphic Medicine International Collective, this is a group who focuses on the concept of graphic medicine. Some journals like Annals of Internal Medicine curate a graphic medicine section. And what that is using comics, usually 3-4 panel comic strips, either for narrative medicine to tell the stories of physicians or those in healthcare, or for patient education and counseling. Oftentimes, things that you see up in clinic offices or patient materials that have comics or sort of fall under this domain. And I received an email from one of the editors of the Annals of Internal Medicine, Graphic Medicine section, saying we're looking for stories of frontline workers during the COVID-19 pandemic, and really want to highlight their stories using graphic medicine. And I had finished my interviews, was coding some data, and I said, boy, do I have some stories for you. So this is where the work turned a little bit more from a paper on transformative learning into a methods paper of can we describe qualitative themes through pictures? So I have three of our comics in the next 3 slides, which I'll read as I show them. But what we did was, these are not exactly exemplar quotes, but they are uh, comic adaptations of quotes that most highlighted the 3 themes that I mentioned earlier. When people heard I was a doctor, they'd treat me like a hero. You a frontline worker? No. I'll give you a discount anyway. Thanks for what you do. I'm literally doing nothing while some kid in India is knitting masks with his feet. They made me sit at home on my hands so I wouldn't expose myself, then call me a hero. I hated it. So again, this was the sense of guilt theme. During the pandemic, if a patient with COVID came in with appendicitis, we probably wouldn't take them to the operating room. This isn't the usual way it's done in the US, but at the time it seemed better than exposing the whole surgical team to COVID. It altered our opinion on how we manage surgical patients in general. Do we really need to take all these people to the OR? It's life-changing when you take a step back and realize that there are a lot of ways to manage patients. This is a general surgery resident who, again, during our interviews found that it was very, she knew about studies that were comparing antibiotics to surgery, but understood that standard of care for acute appendicitis in the US is surgery. These were, the students didn't draw these, or the residents, thank you for that question, Rebecca. These were done by Michael Green, who is a member of our research team and is the editor of one of the graphic medicine section of Annals of Internal Medicine. But no AI. This is pen and paper and colored pencils and various sketches that ultimately were polished prior to journal submission. I love the concept of using AI for these in the future. That'd be really cool. Or as well having the research participants do their own drawings. And this is one of our fellows. Pre-COVID, I had a monthly meeting scheduled with our head chaplain as part of my fellowship program. Meeting today? Let's cancel, too much going on. Okay, maybe next month. Then the pandemic hit and we began to meet more frequently. Whoa, our hour is up already? Can we have more time together? And then I'll point out that this 1 year later, this was the gentleman there in the yellow orange shirt is me conducting my research interviews with this fellow. These conversations made me think a lot about the past year, what the past year has been like, and how different things truly are now. I was surprised because even though I had been immersed in COVID, I hadn't thought about it much at all until this interview. So one of the themes that we found here as well in these processes and venues for reflection was that the research interview itself often served as a venue for reflection and transformation if residents hadn't or fellows hadn't had the time to process prior to this. So moving forward, I briefly mentioned ways that we used art to display transformative learning. But I'll ask the question, can you foster transformative learning with art? So this was our final work of scholarship that I'll discuss today before turning it over to you all. We looked at, and this is, I'll highlight, this is a great example of student participatory research. The first author there is a Canadian medical student that was amazing in this project. But can the arts and humanities, using that social advocacy or social change lens of transformative learning, lead to such transformation? So we did another literature review adapting from a critical narrative review in academic medicine in 2021, where they looked at just all arts and humanities in medicine. And we specifically pulled out articles that promoted social advocacy and then dug into them to see what components of transformative learning existed. And additionally, we supplemented that search, trying to find a little bit more about the how of using arts and humanities to foster social advocacy. Dug into MedEd Portal a little bit. And things that we found in this endeavor was the main focus of the use of arts and humanities in creating, or I guess in fostering social advocacy was around the creation of the disorienting dilemma. So oftentimes, whether it be art or music or going to a museum, often theater came up, including engaging learners in theater themselves. Was used in the creation of that dissonance, in that disorientation. There was very little written about how to move the learner from step 1 to step 2 to step 3 to step 4, etc. So that brings me to some of the work that I'm doing now with a few members on this call is, do we have enough reflection venues within healthcare? I know we have reflective practice assignments in the medical school and in residency, but is that enough? What is the faculty role in moving learners from challenging experiences to ultimately an open and more inclusive worldview? And I'll bring up this slide again. And I think it is key to have not only these reflection venues, but faculty, including all of you on the call today, to really move learners from that disorienting dilemma through reflection, through discourse, and into action, so they don't develop increased cynicism and ultimately lead to that more open and inclusive worldview. So what do you want to change? I'll turn it over to the audience here, and I'll give some prompts as well as go to a question slide, and want to hear from you all about what are your passions? What are your passions that you think students should also be passionate about, or residents or fellows should also be passionate about, and how do you get them there? Are there disorienting dilemmas that exist? Things that students will run into that you don't necessarily need to create, but that you can harness, that you can um, uh, uh, highlight, that you can debrief on, or like the arts and humanities literature, do you need to bring something novel into the curriculum and share that with the learners so they do have something on which to question their worldview? What reflection venues do you have for your learners? If you have them, is this reflection structured? Are there mentors involved to lead them to that transformational change? And left a bit of time for questions and comments, but let me hear how I can help you get there. Again, thanks for your attention and looking forward to our discussion.
Ben, may I jump in?
Please, Jen, thank you.
Thanks so much for this presentation. This is really interesting. I'm thinking about the reflection piece of this a little bit and know that as part of your LIC curriculum and ours broadly, that reflection is part of the core curriculum. Have you thought intentionally about the theory around transformative learning and incorporating that into the reflective writing and discussion? Or have you seen that play out in some of those discussions?
Yeah, great question, Jen. Thank you. So this is I would say the third year that I've done a reflective practice assignment around this. And the first 2 years I had sort of, I'll call them TED Talks. That's what they were, to sort of prompt the students to sort of give them that disorienting dilemma. And I'll admit the reflections I got were kind of bland afterwards. And I had sort of similar like prompting questions for them in it. This year I dug in, this was fairly recently after I finished the Arts and Humanities project, and I actually did a song that was about 3 brothers who were in a band and their dad was dying. And it was a song that they wrote about their experience of that. And it was very blunt about the end of life experience. And the richness of the reflections I got from that were incredible. I emailed 3 of the students and said, this is publication worthy. Like, let me help you get there if that's something that interests you. I think going back to, I mean, I think the depth that you can go into when something is challenged, and many of these students hadn't had an experience with death, and personally, definitely not clinically from the year, having come from the plains, but just the disorientation that they got from that piece of art was something that I couldn't give them just from someone else speaking.
Always have something on the tip of my tongue, Ben. Thanks for this. It sounds like what you're just saying is that we need to, in addition to harnessing, one of your questions was how do we harness opportunities? And I think we could lean into that more because stuff happens all the time in the hospital, but I'm also, and in the clinics, but I'm also wondering about inserting the backup of the artwork, whether it's poetry or music or visual art, as a kind of mandatory piece of things. So that in case we don't have something to talk about that actually was transformative in our experience for the week or something like that, we could have them with a poem or with a piece of art ready to go. We could consider doing that in a really structured way across the entire medical school. And then and not everybody would be transformed every time, but it could start to be part of the culture shift. And I wonder how good of a job we as faculty think about reflect on this ourselves. I think there's been there's a lot of people in our busy lives where we put it away and don't call out the transformation that has the potential to happen. So I see space for faculty development too.
Yeah. Thanks, Shanta. I think I will say it's fairly novel as far as whether or not we can create transformative learning. Because, you know, I'll say it started out as an educational theory, not a teaching theory. Ed Taylor, he's retired out of Penn State, he was sort of the leader in focusing on can we create it? You know, that's sort of where we got the idea of the arts and humanities. I love the idea of having that backup. I think that's super cool in that structure. You know, kind of how I think there needs to be more work into why certain learners will have these transformative experiences and certain don't after the same experiences, to know is the right intervention going to create the right outcome, or do we really need to individualize this? I think that there's a lot we don't know in that space, and it's super interesting. To Deb's point there, thank you for that comment. So as I mentioned in the first literature review we did, transformative learning going by other names, Ballant groups were one of the most common overlaps that we saw there. Not a ton on medical improvisation, but having attended one of your workshops, Deb, I can second that is definitely has significant transformative potential. And to Natalie, to your question as well, has narrative medicine been studied in this context? I don't think formally I've seen a few autoethnographies that sort of the process of writing about experiences ultimately led to the transformation at the end, but nothing more in depth than that.
Do you have a practice that you do now with your team or with your students?
In the clinical space? Mm-hmm. Yeah, a colleague of mine has adopted a moment of humanities. You know, I think I will say I haven't personally adopted that as a separate entity, because I feel like these do need to be, you know, tied with the event that is disorienting if you're not creating it yourself. So oftentimes, if I will see an event and can find some sort of, I'll often call it parlay the creation and the harnessing of the disorienting dilemma. So if I see something that I think has potential, I'll try to bring in either some arts or humanities, or even just developing the discourse around that. I attended one of, I guess it was last Friday, or last Thursday, the ski club. And Dr. Jellens, one of the medicine residents, was talking about DEI rounds. So sometimes I'll use the disorientation that comes from a biased or racist patient, sit down, use that as foster reflection, and I guess me be the member of the discourse team, and hopefully lead to transformation, although nothing that I've studied. I'll turn it back to some of the other folks on the call. What are things that you're passionate about that you want to change, and ways that you could see this being used as a venue to get there?
I'll speak up. Just this is not a fully formed thought at all, and it might not be relevant. But hi, I'm Meredith Bone. I'm physician faculty in pediatric critical care, and I'm working with a fellow in our section through like a wellness perspective on second victim phenomenon, and we're thinking about trainees and how they might experience second victim phenomenon differently when you're like an intern or a resident and a fellow, and then an attending who's been working in clinical spaces and maybe seeing or experiencing second victim phenomenon more often. And so your work in COVID sort of made me relate to that. And so that has me thinking about how does this theory connect with what we're studying, and just like maybe a different we are planning a qualitative look at it, but we haven't yet set up that study. So that is what I'm thinking about.
Thanks for your comments, Meredith. One of the things that we're finding in some work that I'm doing with James and Natalie on this call is the preconceived notions of learners going to various clinical spaces about what the goal of that clinical space is, and whether that is to just be a knowledge sponge, whether that's to process emotional experiences, whether that is to have a transformative experience, whether that's to choose the career you want. And I think that one thing that we're finding in this domain, and in a new study with the same theoretical framework, is going into I guess preconceived notions going into the clinical space can impact how much reflection is done and how much debriefing or discourse is done, even if they have some structure or the mentors in place to do that. So I think if like second victim phenomenon, I think would be a really interesting thing to study, not only as an outcome, but what were the preceding events that led to that. So thank you for that comment. Well, I see the, oh, sorry. Would you consider burnout? Would you consider burnout to be a disorienting experience? What could be done to counter that? Yeah, I think it would be a disorienting experience. I think if, depending on what it leads to, thanks, Mary, depending on what it leads to, is going back to that Stranger Things slide, is whether or not I would call it transformative learning, right? If you are personally burnt out, or you're studying burnt out, or studying burnout, or learning about burnout, and try to change the world like Dr. Derby's doing, right? Versus seeing that same experience and quitting medicine. I think that those are two different outcomes from the same disorienting experience. But yeah, I definitely see that as burnout. Or sorry, burnout as a disorienting dilemma. Great question though.
Ben, thanks again for the talk. I just want to, I think it's actually our responsibility to create opportunities for different kinds of learning to allow for what I would call mini transformations. I think big transformations come mostly from adversity because of the way people are made. But anyway, one other thing that's happening at University of Colorado, I want people to know about. My colleague Alex Reed is doing something that he's developed with someone else called a perfect day, where he takes family medicine and OBGYN residents away for a day and takes them to wherever they want to go and eats food that the resident has picked. And he has a structured reflective interview that goes back to like childhood, and it just discusses the meaning of being a doctor and the hardest parts. And anyway, and folks are reporting loving that experience and feeling that it's transformative and healing for them. So, and it's a kind of thing, it's positive, and it's something you would never do in a million years. In fact, it seems weird to do. And yet, because of that, the brain works in different ways and can allow for these mini transformations. So thank you for this talk. I love thinking about ways we can bring meaning and transformation into medicine through active and non-traumatic things.
Yeah, thank you, Deb. I think that's a great example. It reminds me a little bit of one of the experiences that I've used on occasion, and also have seen in literature, is having learners at any stage, or even faculty, rereading personal statements that they've written to get into medical school, residency, fellowship, et cetera, to sort of reground you in the values that led you there. And yeah, I have a little, I have too many ideas to count in your domain about fostering guided reflection. So we'll talk offline. Thanks, Rebecca, for that question. I think working with patients who have acute, but probably more often chronic pain can be very disorienting, and I would say can lead to that hidden curriculum and that cynicism. So I think trying to get ahead of that in your pain science and management elective will be really beneficial. James, see your hand up.
Yeah, so I'm working with Ben on the project where we're looking at student experience in the adult ICU. And I think one thing I've been thinking a lot about from that, but also just my own experience as an ICU fellow for the last year and a half, is just how I think we tend to over-index on like interventions to target students and residents and say like, okay, how do we do something to like make this better for them? We know this isn't happening. How can we change it? And I think a lot of what I've thought about is how a big part of this is like students don't see this modeled, and so they don't see this valued as like a part of their professional life. And so sometimes I wonder about when we think about interventions that are divorced from the clinical space, if that's a way of saying that like we don't have space for your feelings and emotions here in the ICU or on clinic or wherever. Like you need to go to a separate student only reflection to have that. And there's certainly some benefits to being with peers like that. But I also think I've been thinking a lot about just like, what did it take at the faculty level for people to recognize like for themselves that this is actually work that they can still be doing for their own development, and how modeling that for other people lets them know that it's okay to do this and doesn't have to be this like other part of your development.
Yeah, I think that takes a bit of humility and from the faculty, as well as insight. I think that could be cultivated further. James is doing great work, by the way, on this stuff. I'll plug him. He's gonna have tons of transformative learning work coming out. Stay tuned. So thank you for attending. I'll stick around for the next few minutes if you have anything that you didn't want to leave for the large group. I see the Qualtrics survey up there. Give me feedback on the talk. Looking forward to hearing from that. And thanks for your attention and spending the lunchtime with me.
Thanks so much, Ben. Very much appreciate it.
Thanks, Linda.